in front of you, the Casino Royale, as they say. It is the pathological gambling. Persistent and recurrent maladaptive gambling that causes economic problems and significant disturbance in personal, social, and occupational function. What are the aspects of maladaptive behavior? Because gambling as a profession has been granted both in the United States, in the European countries, and in Sweden, and in Bhutan. Gambling is normal there. There no one is punished for gambling. But when it is pathological gambling, the aspects
even in India, race is allowed. That is also gambling.
Race is allowed, but pathological gambling in the sense of casinos. Casinos is not allowed. Lottery is allowed. Lottery is the biggest form of gambling we have in our country. It is a preoccupation with gambling. A preoccupation that the person forgets all other activities. The repertoire, social repertoire is kept aside, and the person is only preoccupied with gambling. He needs to gamble. I am using the word he because it is mostly commonly seen in males. He needs to gamble with increasing money to achieve the desired excitement. Repeated unsuccessful efforts to control, cut back, or stop the act. He gambles to recoup the losses. He lies to conceal the extent of involvement, how much he has lost money. Commission of illegal act to finance gambling. Like in banks, they give false drafts and checks, counterfeits. Reliance on others for money to pay off the debts. This is the basic characteristic trait of the gamblers, at least the pathological gamblers. Prevalence is 3 to 5%. White men of comfortable economical background, aged 35 to 50 years, generally do this gambling. Comorbidity is there. Full-blown OCD is uncommon. Full-blown OCD is very much uncommon. Now coming to one important aspect, a lot of studies is being done on pathological gambling because it will find a place in DSM-5. I will tell later. According to the newer studies and the recommendations by Eric Hollander, who is in charge of the anxiety portion and OCD portion of the DSM, pathological gambling is going to come. They have studied abnormalities of platelet MAO activity, increased cortisol level in saliva while they gamble. I was telling previously that the hypothalamo-pituitary axis might play a role. Course and prognosis we know. There are 4 phases of this gambling. The winning phase, when he starts spending rupees 10 and gets rupees 20. Excuse me, sir. The winning phase, when he gives rupees 10 and earns rupees 20. The progressive loss phase, when he gives 2000 and gets nothing. The desperate phase, when he has to recoup the losses. And the hopeless stage, when he has nothing to lose, nothing to gain, and he has become a beggar. Treatment. This is the only condition among all the impulse control disorders which requires emergency hospitalization, because helps removing the patient from the environment. Insight-oriented psychotherapy, family therapy, there is Gamblers Anonymous like Alcoholics and Narcotics Anonymous, cognitive behavioral therapy, pharmacotherapy, naltrexone, SSRIs, and carbamazepine have been used, and studies have reported. We come to one of the common impulse control disorders what we see daily in our clinics. This is trichotillomania, coined by the French dermatologist Francis Halopio. Recurrent pulling out of one's hair resulting in noticeable hair loss and increasing sense of tension immediately before pulling out the hair or attempting to resist the behavior, pleasure, gratification or relief during pulling out the hair. We know all this. The prevalence is about 0.6 to 3.4%. The comorbidities are OCD, Tourette, affective illness, eating disorders, personality disorders, mostly OCPD, borderline and narcissistic personality disorder. Pathology and lab examinations are there. The course is there. About 1/3 of the patient subsides in 1 year. In some cases, it lasts for 2 to 3 decades. Treatment. It involves both the psychiatrist and the dermatologist. Hydroxyzine hydrochloride, topical steroid. Among the antidepressants, we are using clomipramine, trazodone, fluoxetine, sometimes augmentation with pimozide and SSRI if necessary. Other drugs for intractable trichotillomania are lithium, clonazepam, naltrexone. Most important is habit reversal training and behavioral therapy. Now, what is the psychobiological basis of trichotillomania as an obsessive compulsive spectrum disorder? As with OCD, there is some evidence of basal ganglia involvement in TTM reported by Stein et al. In 2002. It is also notable that most common impulse control disorder in OCD is skin picking, and that range of other body focused behaviors such as nose picking, lip chewing are common in TTM. Christian and Pro, 1996. So this is the question for the hall. Are you sick and tired of being tired? This is what the OCD patients say after 2 to 3 years when they do not respond to the treatment. We try our best, we do our best, but something somehow fails. What fails, we do not know. The other impulsive disorders are sexual addiction, compulsive buying, internet addiction, cellular phone addiction, and skin picking. Neurological disorders. Tourette syndrome. Tourette syndrome is a prototype of the tic disorder, which is a sudden repetitive stereotype non-rhythmic movement, motor tics and utterance phonic tics that involve discrete muscle groups. Coprolalia is often present, spontaneous utterance of socially objectionable or taboo words or phrases. Tourette syndrome and OCD, what are the similarities? They have been pointed out. Both are associated with repetitive act, both have a chronic course. Similar illness in the first degree relative. Group A, hemolytic streptococcus, is associated with both the conditions. SSRIs are effective in both the cases. What are the dissimilarities? Tourette syndrome is mostly dopamine pathway is implicated, and that is why we use the antidopaminergic drugs. Whereas in OCD, we use the SSRIs. Different anatomical region of brain is associated. So treatment of today is given: typical antipsychotic, haloperidol in low dose; atypical antipsychotic, risperidone, please don't mind the spelling, olanzapine; fluoxetine in resistant cases, augmentation with pimozide or clonidine. Behavioral therapy can be used as an adjunct. Psychobiological basis of Tourette syndrome as obsessive compulsive spectrum disorder. It seems clear from the results of family and twin studies that OCD and Tourette are genetically related. Shavit et al. 2006. He has published more than 11 papers on Tourette syndrome and obsessive compulsive spectrum disorders. In Tourette syndrome, on the other hand, dopamine blockers are useful for tics, but SSRIs may be useful for the treatment of comorbid OCD. Sydenham's chorea, we all know about it. Rapid uncoordinated jerking movements affecting primarily the face and feet and hands. Recovery is more than spontaneous in 50%. Treatment is IV antibiotic. Sometimes we have to use haloperidol for the movement. Valproate can be used. Torticollis or wry neck is there. Head is tilted towards one side and chin is elevated and turns towards the opposite. Causes may be congenital, acquired, and these are the causes from the orthopedic side. Treatment, gentle stretching exercises. So who needs the help? Do we need the help, or do the patients suffering from OCD or OCSD or whatever we might call them, they need the help? Everyone needs the help. Autism. Marked impairment in reciprocal and social and interpersonal interaction, absent social smile, lack of eye-to-eye contact, lack of awareness of others' existence or feelings, treating people as furniture, lack of attachment to parents, lack of imitative behavior, absence of fear in presence of danger. Treatment, we know, behavioral therapy, psychotherapy, pharmacotherapy. Antipsychotics, haloperidol, chlorpromazine, risperidone. Others are SSRIs, amphetamines, methotrexate, imipramine, multivitamins, triiodothyronine. Coming to the last part of the OCS, that is spectrum, regarding the body dysmorphic disorders. This lady says, I won't eat. So preoccupation with bodily sensation, eating disorder. Anorexia nervosa, we know all about it. There is a body image disturbance, refusal to maintain body weight above a normal minimum weight for age, sex and height. Significant weight loss more than 25%. Short-term and long-term treatment therapies are there. This person, this image has not come very well. This person lying down and the doctor is telling everything comes out to be normal, whether it is the ECG, EEG. Simplified is hypochondriasis. Persistent preoccupation with a fear or belief of having one or more serious diseases based on the person's own interpretation of normal bodily function or a minor physical abnormality. Preoccupation with medical terms and syndromes, the fear or belief is not a delusion. Fear persists despite assurance to the contrary. Treatment is difficult, supportive psychotherapy, treatment of underlying depression. Hypochondriasis as a part of OCS has been suggested by the following literature. There is some overlap in the pharmacotherapy and psychotherapy of hypochondriasis and OCD. Small database supports this. In addition, it has been proved that SSRI treatment in both the cases can be effective. Coming to this part, where the lady looks at something else. Body dysmorphic disorder. Excessively concerned about and preoccupied by imaging or minor defect in their physical features. Complains of specific features of a single feature or a vague feature or general appearance causing psychological distress. The prevalence is there. Common symptoms are obsessive thoughts about perceived appearance defect, obsessive and compulsive behavior related to the thought. And we know that there is suicidal ideation in high. Treatment is counseling, psychotherapy, SSRI. Depersonalization disorder, alteration in the perception or experience of self. It is as if phenomena. It is accompanied often by derealization, causes significant social, interpersonal or occupational impairment. Distress or anxiety is present, feeling or loss of control, speech may occur. Treatment usually not very successful, though comorbid anxiety and depression. This is the review of literature, psychobiological basis. Clinical similarities between body dysmorphic disorder and OCD include comparable prevalence in both sexes, onset, durate, and chronic illness. So they are compared. There are a lot of studies out there. Now coming to the Indian scenario, have we done some research or enough research in the Indian field? An overview of Indian research in obsessive compulsive disorder by Dr. Y.C. Janardhan Reddy from NIMHANS, Dr. Naren P. Rao, and Professor Sumant Khanna, who was previously in NIMHANS. Jayasuriya et al. Examined the prevalence of putative OC spectrum disorders, comparing the relatives of psychologically ill patients and neurologically ill patients. They found tic disorders 39%, hypochondriasis 13%, trichotillomania 3%. They could not find, rather they have stated, I have that book with me, they did not find any eating disorder, binge eating or hypochondriasis in their study. So they could not report. This was later, this study is now being carried in NIMHANS by Professor Suresh Badamat, as Professor Dr. Shah would know. He is now conducting this study about the comorbidities. So living with obsessive compulsive disorder is a trouble, is a pain, is a distress. Current nosological status, my last two slides. The current status of OCD is included under the anxiety disorder. Impulse control disorders are mentioned as impulse control disorders not elsewhere classified. This is the broad heading in synopsis. Impulse control disorders not elsewhere classified. Hypochondriasis is placed under somatoform. Eating disorder under behavioral syndromes associated with psychological experiences and physical factors, ICD. 10. So Hollander and his colleagues, after doing so much of research, they became confused. They said, where to place this OCD and OCS? Is it a part, diagnostic option 1, is it a part of a big affective disorder, affective spectrum disorder, where depression is here, anxiety is here, addiction is outside this circle, and let us put all this inside the affective spectrum disorder. A small circle within a big circle. So they thought that it is actually the affective spectrum disorders, and all these diseases or disorders fall under this criteria. This was rejected. Then they came with the diagnostic option 2. These slides have been taken from Lundbeck Abbott, which promoted the studies carried out by Dr. Hollander. Affective disorders on one side, addiction on other side, where pathological gambling is going under addiction, and autism is going towards affective disorder, impulse control towards addiction, hypochondriasis in between, OCD, Tourette syndrome is there. Future directions. As proposed by Hollander, OCD should be removed from the anxiety disorder, will be placed under obsessive compulsive spectrum disorder or obsessive compulsive related disorders. As I have previously said before starting my seminar, that what do we know and where do we go? So is there really a place where we can place the OCSD? If so, then where? This is the article I have bought with $31. Is obsessive compulsive disorder and anxiety disorder by Dr. Eric Hollander. It is a big article. He proposes that OCD will be removed from the anxiety disorder spectrum. And he is in charge of the OCD and anxiety disorder research part in APA DSM-5 task force. So what happened? Ultimately his results have come in DSM-5. This is the DSM-5 for anxiety disorders. And you see the respected guests here, teachers. Separation anxiety disorder, panic disorder, agoraphobia, specific phobia, social anxiety, generalized anxiety, substance induced anxiety disorder, other specified anxiety disorder, unspecified. Nowhere there is obsessive compulsive disorder. This has been taken yesterday on the 26th from the DSM-5 task force internet. This is the latest APA home site that, pardon sir? Rakhen. This is the latest taken from the DSM-5 internet. Taken this site. So they have proposed obsessive compulsive related disorders. Previously, when I was presenting in Bardhaman before Dr. Kumar, I presented this entire slide from F00 to F9, which is generally an ICD coding. This ICD coding is given in DSM-5. Obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, hair pulling disorder, skin picking disorder, substance induced obsessive compulsive or related disorders, obsessive compulsive or related disorder associated with a known general medical condition, obsessive compulsive disorders not elsewhere specified. Previously, when I presented, this was there about 1 month back. Other specified obsessive compulsive or related disorder. This has been marked in red because this has now been removed. And all have come up with one. That is F9 has become F8. They have removed this. So Hollander says recent advances, particularly neurogenetics and brain imaging, have contributed to our understanding of OCD and OCD spectrum. Nevertheless, the data from psychological studies comparing OCD with putative spectrum disorders have yielded mixed findings. He has also told that there is a mixture, there is a grey zone which cannot be delineated clearly. The concept of an OC spectrum disorder may be clinically valuable insofar as it encourages appropriate diagnosis and treatment of a number of disorders that are often overlooked. Hollander, on the other hand, says that patients suffering from OCD generally present to the clinics with vague anxiety symptoms. OCD is a disorder which has to be probed for. One has to ask about the OC symptoms, and only then the OC symptoms come. Whether it be tics, whether OC related disorders, whatever be in the spectrum, they will present with vague somatic symptoms. No one will come and say, I am having repetitive intrusive thoughts. It has to be probed, and then the surface presentation will come. Conclusion: although the obsessive compulsive disorder has been described since 5th century, it was thought to be rare. Now it is the 4th most common disorder after substance abuse, major depressive disorder, and social and simple phobia. OCD was often thought to be an affliction requiring religious intervention. The Catholic Church of Rome labeled the condition as excessive scrupulosity, when rituals and compulsions were exhibited by priests and parishioners. OCD is unique among the anxiety disorders by appearing to be much more dominated by cognitive and related complex behavioral symptomatology, with automatic dysregulation playing little role. This is the bibliography in short. So the child who was playing in the field has come, he has found a partner. The partner may be the treatment. So it is support from the family, support from everyone that heals OCD. We only prescribe. but the healing is in the hands of God. Before you ask questions, I have given the picture of a dinner sitting together to escape the questions. Thank you, sir. Thank you.
দুটো তিনটে জিনিস আমার মনে এলো, সেগুলো বলছি, মানে হাউসের কাছেই বলছি, লেট আস ডিসকাস। এক নম্বর হচ্ছে ওসিডি আর